Welcome. Managing complex conditions like fibromyalgia, dysautonomia, and small fiber neuropathy requires a strategic, integrated approach. We've developed the Everyday Playbook to bridge the gap between clinical theory and daily life. By synthesizing the latest 2026 guidelines with neuroplastic pain research and multidisciplinary care models, we've created a holistic roadmap for recovery. Today, we'll move beyond isolated symptoms to explore actionable insights that empower you to reclaim health, one day at a time.
Think of your brain as an internal pharmacy, naturally producing chemicals like opioids to manage pain and regulate mood. However, when we are sleep deprived, this sophisticated system begins to falter. The delicate neurobiological pathways responsible for our resilience effectively start to jam. By missing out on restorative rest, we are essentially dimming our body's innate ability to protect itself, leaving us far more vulnerable to both physical pain and emotional distress. Historically, we viewed sleep as a passive state of rest, dismissing post-sleep pain as a simple byproduct of fatigue. However, modern clinical perspectives have shifted. We now recognize sleep as an active, vital component of the body's pain relief infrastructure. It proactively maintains the pathways that suppress pain signals. When sleep is disrupted, patients don't just feel tired, they face spontaneous headaches and systemic hyperalgesia. Sleep isn't merely recovery, it's a critical active modulator of the human pain experience. Think of your body's pain processing as a delicate balance. When rested, your internal brakes, conditioned pain modulation, actively suppress daily discomfort to maintain equilibrium. However, sleep deprivation catastrophically disrupts this system. It physically snaps those inhibitory brakes while simultaneously slamming the accelerator of pain summation. This shift leaves the body vulnerable. Your natural ability to dampen pain is compromised, lowering your threshold and amplifying even minor sensations into persistent, heightened discomfort. Your body possesses a remarkable inner pharmacy that produces natural opioids to keep pain in check. This system, known as conditioned pain modulation, acts as your primary defense against discomfort. However, chronic sleep deprivation causes a physical breakdown of this mechanism. It's more than just feeling tired. Your neurochemistry is being robbed of its own natural painkillers. Without restorative sleep, your brain literally loses its biological ability to dismantle pain before you even feel it. The MHB-IPN pathway is essentially our brain's command center for restorative rest, boasting the highest concentration of mu-opioid receptors. In a healthy state, natural opioids activate the circuit to trigger deep, slow-wave sleep. But here's the problem. Sleep deprivation effectively short-circuits this hub. By suppressing serotonin, it breaks the brain's ability to initiate recovery. We aren't just tired, we've lost the neurological key to the very sleep we need to function. Think of your brain's natural pain management as a system of locks and keys. When you're well rested, internal painkillers bind seamlessly to their receptors, providing effective relief. However, sleep deprivation triggers a catastrophic change by aggressively stripping away these receptors. Even if your body produces natural relief, those chemical keys suddenly have nowhere to bind. By losing these vital locks, your internal defenses vanish, leaving you significantly more sensitive and vulnerable to physical pain. Think of your nervous system as a complex spring. Normally, restorative slow-wave sleep acts as a natural brake, dampening pain signals before they become overwhelming. However, when sleep is disrupted, these protective opioid brakes fail. This triggers central sensitization, where repeated pain signals cause the nervous system to wind up. Instead of habituating to the discomfort, your brain amplifies every signal, leading to a state of heightened sensitivity and chronic, self-perpetuating pain. When we lose sleep, our body's ability to process painkillers drastically diminishes. Common opioids like morphine rely on specific receptors that sleep deprivation physically dismantles. As sleep debt accumulates, the very medications meant to help become less effective, leading to a dangerous need for higher dosages.
This highlights a critical clinical reality. If we aren't managing a patient's sleep, we aren't effectively managing their pain. Rest isn't just recovery, it's the foundation for treatment success.
Beyond the opioid system, chronic REM sleep deprivation triggers a devastating dopaminergic collapse. When we lose sleep, we see a dramatic drop in dopamine input to the prefrontal cortex and a downregulation of key receptors. This isn't just about reward, it's about resilience. Without this chemical support, our emotional ability to manage chronic pain evaporates. This leaves us trapped in a cycle of heightened physical sensitivity and deepening mood disturbances that make recovery feel nearly impossible. Now let's examine our second co-conspirator, a severe endocannabinoid shortage. Chronic sleep disruption directly impairs signaling within the thalamic reticular nucleus by draining levels of NADA, a vital endogenous cannabinoid. As sleep debt accumulates, these levels plummet, causing a significant drop in CB1 receptor activity. This deficiency effectively strips the brain of its natural defenses, leaving our internal regulatory systems compromised and unable to maintain healthy function during periods of persistent sleep deprivation. Sleep deprivation does more than make you tired. It fundamentally dismantles your body's natural pain management. When you're sleep deprived, your opioidric system loses its analgesic power, making pain harder to block. Simultaneously, your dopamine pathways weaken, stripping away your ability to cope with physical distress. Finally, a collapse in the endocannabinoid system triggers heightened sensitivity. Together, these neurochemical shifts explain why discomfort feels unbearable after a sleepless night. Without rest, your internal pharmacy essentially closes. Sleep deprivation triggers a devastating multi-system collapse within our brain's descending pain inhibitory pathways. It isn't a single point of failure, it's a coordinated breakdown. As our internal opioid brakes fail, dopamine-driven coping mechanisms crash, and our endocannabinoid systems deplete, leaving us hypersensitive. This cascade creates a perfect storm, stripping away our natural defenses and leaving us vulnerable to chronic pain. We are witnessing the total failure of the networks designed to protect us. We cannot effectively treat pain if we ignore the foundation of recovery: sleep. Sleep deprivation dismantles the body's endogenous opioid system, making external painkillers feel like a losing battle. To break this vicious cycle, our priority must shift. Restoring slow wave sleep is a primary analgesic intervention, not a secondary concern. By fixing sleep continuity, we reactivate the body's inner pharmacy, providing the essential biological infrastructure required for real healing and relief to occur. To truly understand chronic illness, we must map the architecture of nervous system dysregulation. It is a systemic breakdown where central processing misfires in the brain cascade through sensitized neural pathways. This creates a state of autonomic anarchy within our internal networks, often pushed to the limit by external chemical triggers. By synthesizing these central errors and autonomic disruptions, we can finally decode the complex patterns of persistent physiological distress. Think of your nervous system as a master control room that has become dangerously vulnerable. When central command falters, the breakdown isn't isolated. It triggers a cascade across our cognitive, spinal, and autonomic networks. This autonomic anarchy leads to systemic failure, where pain and dysfunction become deeply intertwined. Crucially, external factors like surgeries or certain medications act as acute stress tests, pushing these already fragile, sensitized networks to their absolute breaking point. Alpha-synuclein deposits cause extensive neurological damage, driving the multifaceted symptoms of dementia with Lewy bodies. While these toxic proteins disrupt thought and emotion within the cortex, DLB uniquely targets the brainstem and dopamine-producing neurons. This results in a devastating combination of Parkinsonian motor failures, autonomic dysfunction, and severe sleep disorders. It is this aggressive multi-system assault that distinguishes DLB pathology, creating a complex web of cognitive, motor, and psychiatric failures that define the patient experience. Progressive dementia that disrupts daily life is the central challenge here. For a probable diagnosis, patients must exhibit at least two core features: fluctuating alertness, detailed visual hallucinations, REM sleep behavior disorder, or Parkinsonism. We also monitor for supportive signs like extreme sensitivity to antipsychotics and autonomic issues. Recognizing this specific combination of cognitive, sleep, and motor symptoms is vital for moving beyond a general dementia diagnosis to more targeted, effective clinical management. Long before a clinical diagnosis, the body sends subtle warnings. Decades earlier, autonomic disruptions like loss of smell and digestive issues emerge as alpha-synuclein begins its silent damage. This often progresses into REM sleep behavior disorder, a critical red flag. Nearly all patients who act out their dreams eventually develop a synucleinopathy. By the time cognitive decline and hallucinations lead to a formal diagnosis, the disease is already advanced, leaving a tragically short clinical window. Accurately diagnosing neurodegenerative dementias requires focusing on the sequence of symptoms. In dementia with Lewy bodies, cognitive decline and motor issues emerge within a year of each other, often featuring early, vivid hallucinations. Alzheimer stands apart through early, prominent short-term memory loss, while motor symptoms remain absent until the end. Finally, Parkinson's dementia is defined by motor impairment preceding cognitive decline by over a year. Mastering these timing distinctions is the key to differentiating these conditions. Think of pain as your body's alarm system. Normally, it's a vital survival mechanism that alerts you to actual injury. However, central pain syndrome fundamentally rewires this network. Damage to the nervous system transforms a functional alarm into a malfunctioning one. In this state, hypersensitized nerves misinterpret safe, everyday inputs as severe threats. The result is a blaring, unremitting pain signal that persists even when there is no physical injury to report. Think of acute pain as a vital alarm. It signals external injury and retreats as you heal. However, central pain syndrome is fundamentally different. It's a neurological misfire. Here, the nervous system either amplifies minor pain or treats harmless touch as agony. This shift from physical trauma to system dysfunction explains why standard painkillers often fail. To find relief, we must move beyond traditional analgesics toward neuromodulators that specifically target these centralized processing errors. A disc herniation is more than a simple mechanical failure. It triggers a destructive biological chain reaction. While the initial breach irritates nerve pathways, the real danger lies in the resulting inflammatory cascade. These chemical markers can burn the nerve, profoundly altering its function. Without resolution, a constant barrage of pain signals risks sensitizing the central nervous system, leading to debilitating chronic conditions like central pain syndrome. Understanding this progression is vital for timely, effective clinical intervention.
Autonomic neuropathy essentially shuts down the body's autopilot. When the non-voluntary nervous system is damaged, often by diabetes or synucleinopathies, critical unconscious functions begin to fail. This systemic breakdown leads to cardiovascular instability, severe gastrointestinal distress like gastroparesis, and genitourinary failure. It even compromises respiratory regulation, causing sleep apnea. Ultimately, when these vital internal signals are severed, the body's most basic, life-sustaining processes can no longer function automatically, placing the patient at serious risk. When you stand, gravity naturally pulls blood toward your lower body. In a healthy person, autonomic nerves trigger instant vessel constriction to maintain circulation. However, for those with orthostatic intolerance, this critical signal fails. This lack of constriction leads to a dramatic drop in oxygen reaching the brain. The result is a complex clinical challenge involving lightheadedness, racing heart rates, and chronic fatigue, symptoms we increasingly see overlapping with conditions like long COVID and fibromyalgia. Think of your gut and brain as connected by a high-speed communication highway called the vagus nerve.
When gut inflammation or bloating occurs, it irritates this nerve, sending chaotic signals upward. Your brain misinterprets this noise as a systemic threat, triggering intense panic and anxiety. This mental state then suppresses your rest and digest functions, further worsening the physical distress. It's a self-perpetuating cycle where physical discomfort and neurological panic constantly feed off one another. Surgical interventions like cholecystectomy can inadvertently trigger systemic reflux. By removing the gallbladder, we eliminate the body's primary bile reservoir, leading to a continuous drip into the digestive tract. This cascade effect results in bile reflux gastritis for over 60% of patients. Because clinical symptoms like abdominal pain and nausea heavily mimic standard GERD, pinpointing the mechanical failure requires advanced monitoring. Understanding this diagnostic overlap is crucial for accurately identifying and treating post-surgical complications. We often credit caffeine for our coffee buzz, but the reality is far more complex. While habitual drinkers develop a tolerance that stabilizes their blood pressure, occasional drinkers experience massive spikes in both nerve activity and pressure. Here's the real anomaly. Decaf coffee produces the exact same cardiovascular response in non-habitual drinkers. This reveals that coffee contains unidentified compounds beyond caffeine that directly stimulate our autonomic nervous system, fundamentally changing how we understand its physiological impact. Think of common psychiatric medications as neurological stress tests. For those with latent vulnerabilities, these powerful modulators can trigger sudden, severe manic episodes or hallucinations. Crucially, this isn't just a temporary reaction. Even after the drug is withdrawn, the brain remains fundamentally altered. Similar to how gestational diabetes predicts future health, these medication-induced events reveal an underlying predisposition, signaling a permanently elevated risk for future psychiatric episodes. This insight is vital for managing long-term patient health. Managing hallucinations in dementia with Lewy bodies presents a dangerous clinical dilemma. While most patients suffer from terrifying visions, the instinct to prescribe antipsychotics can be catastrophic. Because of profound dopamine depletion, these medications trigger severe sensitivity reactions in half of all cases. Even a single dose can cause irreversible Parkinsonism or life-threatening neuroleptic malignant syndrome. We must recognize this trap to ensure that our attempts to treat psychosis don't lead to irreversible harm. Dysregulation isn't an isolated event, it's a systemic cascade. When the central nervous system fails, it destroys peripheral nerves, causing widespread dysfunction from blood pressure to digestion. This creates a devastating loop where gut issues irritate the vagus nerve, triggering intense psychiatric panic. Meanwhile, spinal damage can permanently rewire how your brain processes pain. Ultimately, external stressors, like surgeries or medications, act as the final tipping point for these already fragile, interconnected biological networks. Traditionally, we treat symptoms like constipation, GERD, and dizziness in silos, addressing each as an isolated issue. But a systems view reveals a deeper truth. These are not disparate disorders. They are the earliest alarm bells signaling widespread neurodegenerative disease or autonomic failure. We need to shift our diagnostic focus. Instead of just managing the localized smoke of individual symptoms, we must identify and address the systemic electrical fire driving the pathology from within. Let's explore the pharmacological landscape of the orexin system. Currently, dual orexin receptor antagonists, DORAs, are the standard, FDA-approved treatments for insomnia that work by effectively blocking wakefulness. Conversely, the emerging pipeline focuses on selective orexin receptor agonists. These compounds specifically target the OX2 receptor to actively promote wakefulness. Currently in the clinical development stage, these agonists represent toward precision therapies for managing narcolepsy and other chronic wake promotion disorders. We've engineered the photorexin toggle to achieve precise control over sleep and activity using light. By replacing orexin B's natural hinge with a synthetic azobenzene moiety, we've created a light-responsive molecular switch. Blue light triggers a structural shift from a bent, inactive state to an extended, active conformation. This breakthrough represents the first photoreversible GPCR ligand, enabling us to toggle complex behaviors on and off with nanomolar precision, all without the need for genetic manipulation. We've moved far beyond broad receptor blockades that provide systemic dampening. Our journey has evolved through complex peptide replacements and selective agonists toward the ultimate goal: optogenetic control. By utilizing light-responsive tools like photorexin, we can now achieve real-time, reversible toggling with unprecedented precision. We are no longer just synthesizing drugs. We are iteratively engineering the fundamental switches of human consciousness, mastering the spatiotemporal control required to redefine therapeutic intervention at its most basic level.
We often treat sleep as a luxury, but it's actually a vital biological tool for pain management. Chronic sleep deprivation fundamentally rewires the brain, heightening our sensitivity to pain. However, this shift is reversible. By prioritizing restorative sleep, we can engage our internal analgesic pathways. Our goal is to re-engineer sleep as a primary treatment, restoring neurobiological equilibrium and providing a powerful natural alternative for long-term pain relief. Traditionally, we viewed sleep disruption as a mere symptom of pain. However, modern evidence reveals a powerful shift in perspective. Sleep loss is actually a primary driver of pain sensitivity. Studies show that a bad night's sleep is a far stronger predictor of next-day pain flares than vice versa. This means we can no longer treat sleep as an afterthought. To effectively manage chronic pain, we must prioritize sleep as a core clinical target for relief. Chronic pain creates a destructive cycle where physical suffering leads to sleep impairment, triggering central sensitization and hyperalgesia. This loop makes the body increasingly sensitive to even minor discomfort. However, we have a powerful leverage point: sleep. Even a few hours of lost rest can immediately spike bodily pain and worsen joint conditions. By prioritizing sleep, we can effectively dismantle this architecture of vulnerability, offering a direct path to breaking the cycle and managing chronic pain. When we lose sleep, our body undergoes a dual biological shift that makes pain inescapable. First, we drop the shield. Our natural internal defenses, like endocannabinoids and opioid receptors, are dismantled, leaving us biologically vulnerable. Simultaneously, we sharpen the spear, where sleep deprivation actively amplifies incoming pain signals through heightened inflammation and dopamine signaling. Ultimately, you aren't just feeling more pain, you are losing the very tools your nervous system needs to suppress it. To understand central sensitization, we must examine the neural circuitry driving chronic pain. It begins with ascending facilitation in the dorsal horn, where neurotransmitters like glutamate amplify pain signals. This persistent state is fueled by dopaminergic dysfunction in the prefrontal cortex and amygdala, disrupting emotional regulation. Furthermore, fMRI evidence highlights a breakdown in descending inhibitory pathways, specifically within the PAG and RACC. Essentially, central sensitization occurs when the body's internal gatekeeping and pain control systems are profoundly compromised. We know sleep loss intensifies pain, and now we know why. During healthy sleep, a molecule called NADA acts as a gatekeeper, binding to CB1 receptors to filter out pain signals. But when sleep is chronically disrupted, NADA levels crash, dropping this protective shield and allowing pain to flood the brain unchecked. By strategically restoring NADA, we can reclose that gate, revealing a critical endocannabinoid mechanism that could transform how we manage sleep-dependent pain.
Have you ever wondered why painkillers sometimes fail to provide relief? Chronic sleep loss actually alters our brain's chemistry, down-regulating critical opioid receptors and depleting our natural endorphin reserves. When we administer exogenous opioids, they encounter a system that's effectively dropped its shield. Without functional receptors to bind to, drug efficacy is significantly diminished. Ultimately, sleep restoration isn't just supportive care. It's a physiological prerequisite for pharmacological pain relief to function at optimal capacity. Sleep serves as your body's natural shield against pain. When well rested, a process called conditioned pain modulation actively regulates discomfort, effectively silencing incoming pain signals. However, just 24 hours of sleep deprivation causes this vital defense to collapse entirely. This pain inhibits pain mechanism fails, leaving your nervous system fully sensitized and exposed. Ultimately, without rest, your internal ability to modulate discomfort is broken, significantly lowering your pain threshold and leaving you physiologically vulnerable. In an optimal state, dopamine acts as a precision regulator, keeping our cognitive performance and pain thresholds perfectly balanced. However, chronic sleep deprivation disrupts this equilibrium. By forcing a massive upregulation of D2 receptors in the prefrontal cortex, the brain's vital communication with the amygdala is suppressed. Consequently, you lose the capacity to cognitively gate pain and memory, resulting in both heightened physical sensitivity and a significantly altered emotional state. Imagine the nervous system's response to pain as a sharpening spear. It begins with repeated stimuli reaching the spinal cord, but the real shift occurs during the wind-up. Under conditions like sleep deprivation, the central nervous system begins to amplify every incoming signal. This creates a feedback loop of central sensitization, leading to hyperalgesia. The result is a patient who experiences a pain response that is dramatically disproportionate to the actual physical trigger.
When we lose sleep, we aren't just tired, we become physiologically more sensitive to pain. Sleep deprivation disrupts 4 critical pathways. It disables natural pain gating, reduces the efficacy of traditional painkillers, and alters our emotional perception of discomfort. This creates a state of systemic sensitization. To effectively manage chronic pain, we must look beyond standard analgesics. Our strategy must prioritize sleep restoration and targeted interventions to reset these biological mechanisms and break the cycle of hyperalgesia. We often believe catching up on sleep over the weekend fixes a week of late nights, but this is a dangerous illusion. Even with extra rest, your body fails to reset the metabolic dysregulation and physiological stress caused by chronic sleep loss. You never truly return to a healthy baseline. Instead, you enter the new week with a vulnerable nervous system, leaving you far more susceptible to stress and pain triggers. Think of sleep as more than just rest. It's a form of physiological armor. Operating on a standard baseline leaves you vulnerable, where even brief deprivation causes sharp spikes in cognitive impairment and pain sensitivity. However, by proactively banking sleep, getting 10 hours before a high-demand period, you build a resilient buffer. This armor significantly blunts the impact of future sleep loss and accelerates your recovery, ensuring you remain effective and resilient when the pressure is on. To effectively treat chronic pain, we must understand the brain's internal recovery cycles. REM sleep is essential for unlearning maladaptive pain responses, but it's impossible to achieve without sufficient dopamine. By selectively activating the D2 dopamine pathway, we can biologically unlock REM sleep, even in depleted states. This tells us that stabilizing dopaminergic tone does more than improve mood. It restores the neurological foundation required to reset the brain's pain architecture and provide lasting relief. To re-engineer patient relief, we must stop treating insomnia and chronic pain as separate issues. By integrating CBTI and CBTP into a unified hybrid approach, we can simultaneously dismantle sleep arousal conditioning and maladaptive coping. This synergy does more than just improve rest. It breaks the vicious cycle of inflammation and hyperarousal. By targeting both nodes together, we effectively repair conditioned pain modulation and proactively prevent the onset of new chronic pain incidents. We often treat sleep loss as a symptom of pain, but it's actually the ultimate analgesic. Chronic pain fundamentally breaks the brain's neurochemical architecture, stripping away our natural chemical shields while heightening central sensitization. The reality is that we simply cannot out-medicate an exhausted nervous system. Restoring sleep isn't just a comfort measure,
It is the essential biological prerequisite for lasting pain relief. If we want to heal the body, we must first quiet the mind. Substance P is the body's master alarm, a crucial 11 amino acid neuropeptide that dictates how we respond to threat. While it is essential for our survival, its role is far more complex than just signaling pain. When this pathway is triggered chronically, it leads to sensitization and fuels systemic disease across the body. By understanding this biological messenger, we gain deep insights into how acute protective responses can unfortunately evolve into persistent pathological states.
Substance P is a remarkably versatile peptide, acting as a multi-dimensional messenger across our body. In the nervous system, it's a primary driver of pain perception and emotional regulation. But its influence extends further, bridging the gap to our immune and vascular systems. By triggering neurogenic inflammation and promoting potent vasodilation, Substance P plays a pivotal role in how we coordinate physiological responses to injury and stress across these interconnected systems.
To understand how neuropeptides like Substance P function, we must look at their origin. The TAC1 gene serves as the master blueprint, using alternative RNA splicing to generate diverse mRNA isoforms. This complex process ultimately synthesizes the active 11 amino acid tachykinin. Crucially, the conserved carboxy terminal sequence acts as the precise biochemical key required to unlock the NK1 receptor, illustrating how genetic precision translates directly into functional biological signaling. To understand our survival response, we must look at how Substance P travels rapidly to reach critical junctions. This alarm system bridges our periphery and the brain. It begins by sensing environmental extremes and transmitting pain signals through the spinal cord. Once in the brainstem, it triggers autonomic vigilance and emetic reflexes. Finally, it activates the amygdala to regulate fear and stress, effectively coordinating a total body reaction to potential danger. Our primary focus is the neurokinin-1 receptor, a sophisticated transmembrane gateway with an overwhelming affinity for Substance P. Crucially, this mechanism operates through volume transmission. Rather than requiring tight synaptic proximity, Substance P diffuses through the extracellular space to activate distant receptors. This process effectively expands its radius of influence, allowing for broader, more complex signaling pathways throughout the nervous system. Understanding this expansive reach is key to mastering the target's therapeutic potential. When Substance P binds to the NK1 receptor, it ignites a powerful intracellular chain reaction. This cascade cleaves secondary messengers, triggering a massive flood of calcium that fundamentally alters the cell's internal environment. Most importantly, this signal reaches the nucleus to initiate genetic remodeling. By activating transcription factors like NFKB, the neuron upregulates pro-inflammatory cytokines, rewriting its own genetic code to maintain a heightened state of chronic sensitivity and alert. Our body's master alarm is a biological double-edged sword. In its acute phase, it acts as a vital first responder, driving rapid healing and life-saving reflexes. However, when the biological off switch fails, this system becomes highly destructive. It transitions from a protective mechanism into a chronic pathological state, fueling systemic inflammation and psychological distress. Ultimately, the very system designed for our immediate survival can become the primary driver of long-term disease and physiological breakdown. In chronic pain states, our nervous system undergoes a profound shift called synaptic amplification. When primary C fibers endure persistent stress, they release Substance P alongside glutamate. This triggers a prolonged depolarization that dislodges the magnesium block from NMDA receptors. This windup leads to a massive calcium influx, making postsynaptic neurons hyper-excitable. Ultimately, the spinal cord becomes so sensitized that even a gentle touch is registered as severe pain, a debilitating condition known as allodynia. Substance P does more than just transmit signals. It actually reshapes how we perceive the geometry of pain. Through volume transmission, It escapes the synapse to hijack neighboring cells, broadcasting alarm signals far beyond the initial site. This process chemically reprograms our neurons, expanding their receptive fields. Consequently, a signal once confined to a tiny area is amplified across a much wider region, transforming localized injury into widespread diffuse tenderness. Let's explore the critical role of substance P in chronic pain. Clinical data reveals a direct correlation between elevated concentrations and disease severity. In fibromyalgia, a threefold increase in cerebrospinal fluid marks a fundamental shift in central pain processing. Similarly, in rheumatoid and osteoarthritis, rising levels in synovial fluid don't just spike pain scores, they drive cartilage destruction through VCAM1. Substance P is clearly a pivotal driver of both nociplastic and inflammatory pathology. Sleep disruption isn't just a side effect of pain. It's a neurochemically driven state of hyperarousal. Persistent pain inputs elevate substance P, which infiltrates the brain to block restorative, slow-wave sleep. This deprivation then triggers systemic oxidative stress and neuroinflammation, which further increases substance P levels. We're left with a vicious, self-sustaining loop, where pain creates insomnia, and that insomnia directly heightens pain sensitivity, making recovery an uphill battle.
At the intersection of mood and trauma, the TAC1 system is a critical driver. Overactivation fundamentally disrupts how the brain processes stress and fear. In the amygdala, trauma triggers a sustained release of substance P, activating the HPA axis and fueling the intense anxiety seen in PTSD. Simultaneously, elevated substance P in the raphe nucleus interferes with serotonin and dopamine pathways, driving the profound anhedonia and depressive symptoms characteristic of major depressive disorder.
While we often treat fibromyalgia, depression, and insomnia as distinct conditions, they are actually overlapping expressions of molecular-level chronic overload. At the heart of this nexus lies chronic NK1 receptor activation. This central node drives the cascade of nociplastic pain, psychiatric distress, and the breakdown of sleep architecture. By shifting our focus from individual symptoms to this unified biological driver, we unlock a theoretical framework for treating the entire cluster of centralized sensitization syndromes through a single targeted intervention. The development of NK1 receptor antagonists highlights a critical journey in pharmacology. While we've achieved remarkable success in controlling chemotherapy-induced nausea by blocking substance P in the medulla, human pain management remains a complex paradox. Despite promising animal results, these drugs haven't yet translated into human analgesics, likely due to biological redundancies, like CGRP. Today, our focus shifts toward dual receptor antagonists and early interventions to finally master this elusive off-switch for chronic pain.
Substance P is our biochemical translation of danger, a true double-edged sword. It begins as a vital first responder, essential for tissue survival and healing. However, it can quickly escalate, transforming from a protective signal into a systemic driver of chronic distress. When this alarm fails to shut down, it triggers allostatic overload, fueling conditions like fibromyalgia and depression. Our challenge is learning to silence the alarm once the fire is out.
Think of fibromyalgia, small fiber neuropathy, and dysautonomia not as isolated silos, but as interconnected manifestations of nervous system dysregulation. While symptoms vary, from burning nerve pain to heart rate instability, they share a crushing reality of profound fatigue and cognitive fog. Crucially, 64% of chronic pain patients also exhibit dysautonomia. By shifting our focus from individual labels to this central systemic dysfunction, we can better address the complex, overlapping challenges these patients face every single day.
Chronic pain and fatigue often trap us in a self-perpetuating cycle. When a flare occurs, our natural instinct to avoid activity and withdraw can lead to physical deconditioning and a hypervigilant nervous system.
Over time, pain and fatigue actually start dictating your body's baseline. However, we can disrupt this loop. By integrating targeted medications, paced activity, and behavioral retraining, we can shift the nervous system away from sensitization and toward a path of sustainable recovery.
Historically, we've treated health like a broken machine, seeking a single fix for every problem. But for systemic well-being, that one-time cure doesn't exist. We must shift toward a paradigm of calibration. Think of your symptoms as feedback, not just pain. Real management means fine-tuning your habits, adjusting the dials of movement, nutrition, rest, and cognitive load daily. By treating your routines as sliders, you gain the power to balance your health in real time.
According to European guidelines, aerobic exercise remains the strongest recommendation for managing fibromyalgia, but success lies in finding the sweet spot. While prolonged rest leads to deconditioning, high-intensity activity often triggers exhausting flares. Instead, focus on paced, gentle movements like Tai Chi or walking. In this context, form and pacing matter far more than load. These activities actually recalibrate how your nervous system processes pain, allowing you to stay active without triggering a flare.
Managing chronic conditions requires a vital mindset shift. Pushing through pain might feel productive, but it ultimately triggers a crash cycle that lowers her baseline. Think of your energy as a fixed battery. To maintain health, you must learn your energy envelope and respect its limits. Pacing means listening to early bodily cues and choosing to stop before you drop. By staying within these bounds, you avoid severe flares and reclaim a sustainable life. Managing cardiovascular stability requires a multi-layered approach. Start by building blood volume through consistent hydration and increased sodium intake. You can further support circulation by utilizing medical-grade compression and avoiding heat triggers that cause blood to pool. Additionally, switching to smaller, frequent meals prevents digestive-related drops in pressure. Since over 27% of adults navigate multiple conditions, combining these practical tools is vital to protecting your cardiovascular baseline and maintaining wellness. To demystify small fiber neuropathy, we must distinguish between nerve types. While large fibers control vibration and position, often appearing normal on standard tests, small fibers handle pain and temperature. Damage here creates that distinct burning, hot sand sensation. Because routine EMGs miss these, diagnosis requires a skin punch biopsy to evaluate nerve fiber density. To improve outcomes, prioritize stabilizing blood sugar, correcting B12 deficiencies, and utilizing topical anesthetics to provide much-needed relief for your patients. To find relief from chronic pain, we must focus on retraining the nervous system. Cognitive behavioral therapy helps us untangle physical pain from stress and mood, while acceptance and commitment therapy provides flexible tools to manage distress and reduce pain's interference in daily life. Finally, somatic tracking utilizes neuroplasticity to teach your brain that pain signals don't necessarily mean tissue damage. By reversing these learned patterns, we can effectively rewire the body for lasting healing and recovery. Understanding the link between sleep and pain is crucial. When poor sleep disrupts your deep recovery cycles, your body fails to repair muscle microtraumas, resulting in increased stiffness and worse pain the following day. This creates a debilitating vicious cycle. To break it, we focus on circuit breakers like CBTI and a strict circadian routine. By optimizing your sleep environment and tracking patterns, you can recalibrate your body's pain response and reclaim your quality of life. When treating fibromyalgia, our goal is matching the right therapy to the patient's specific profile. Aerobic exercise remains the gold standard, offering the strongest evidence for nearly everyone, as long as they start gently. For those seeking lasting, durable change, resistance training is key. If stress and fatigue are primary concerns, mind-body practices like Tai Chi are excellent. Finally, behavioral therapies effectively address cases where pain is deeply tangled with stress and emotional processing. Medication for fibro, SFN, and dysautonomia serves a vital purpose. It lowers the volume on your symptoms.
Whether we're using nerve pain modulators like Lyrica or circulatory support like Midodrine, the objective is strategic. These treatments aren't just about immediate relief. They are tools designed to stabilize your system. By reducing the daily burden of pain and instability, we create the necessary space for you to engage in the physical and behavioral therapies essential for long-term recovery.
Navigating a diagnosis like dysautonomia requires a true partnership with your provider. Since finding answers can take years, you must be a proactive advocate. Come to appointments organized with detailed symptom data and current clinical research to support your case. On a practical level, always bring water and salty snacks to manage flares during your visit. By being prepared and professional, you ensure that your voice is heard and your health remains the priority. While you cannot control your condition, you can master the ecosystem surrounding it. It's about recalibrating your body throughout the day. This starts with morning hydration and compression, followed by midday pacing and frequent small meals to manage blood flow. In the afternoon, respect your energy envelope with gentle recumbent movement. Finally, prioritize sensory wind-down to ensure restorative sleep. By managing these variables daily, you regain agency over your health and well-being.
Dealing with dysautonomia often feels like navigating a constant internal storm. When your body's automatic functions, the things that should keep you balanced, begin to falter, it impacts every facet of your existence. Today, we shift the focus from merely surviving to active reclamation. By understanding the intricate connections within our nervous system, we can begin rewiring the system through a holistic lens, empowering you to restore balance and take back control of your well-being.
While dysautonomia is often invisible, its impact is immense. Over 70 million people worldwide are currently navigating the breakdown of their autonomic nervous system. Because symptoms span multiple organs, patients are frequently misdiagnosed, trapped in a chaotic maze of specialists for an average of nearly 8 years before finding answers. This isn't just a medical mystery, it's a documented crisis. We must bridge these gaps and provide a clear roadmap for those suffering in silence. Your body operates an automatic control room that manages vital functions without you ever thinking about them. This system balances two main circuits: the sympathetic, which acts as an accelerator for fight or flight responses, and the parasympathetic, which serves as a brake for rest and repair. Together, they form a seamless 3-neuron network that auto-regulates everything from blood pressure to digestion, ensuring your internal environment remains stable and prepared for any challenge. Think of your autonomic nervous system as the body's central dashboard, managing everything behind the scenes. When it short circuits, the effects are widespread. It's not just one symptom, it's a systemic breakdown. Patients face a cascade of issues, from neurological brain fog and erratic cardiovascular signals to severe gastrointestinal distress. These systemic challenges, like extreme temperature swings and exercise intolerance, make daily life a constant struggle. Understanding this complexity is vital for effective diagnosis and care. When we stand up, gravity pulls our blood toward our feet. In a healthy body, the nervous system triggers a vital squeeze, tightening vessels to pump circulation upward and nourish the brain. However, with dysautonomia, these signals fail. Instead of a strong return, blood pools in the lower limbs, starving the brain of essential oxygen. This lack of blood flow, or cerebral hypoperfusion, is why patients experience such debilitating and persistent brain fog. To accurately navigate this diagnostic spectrum, we must distinguish how the body responds to standing. With POTS, we see a significant heart rate spike without a drop in blood pressure. Orthostatic hypotension, however, is defined by a sustained fall in blood pressure due to vascular failure. Finally, neurally mediated syncope involves a sudden reflex-driven crash in both vitals, leading to fainting. Recognizing these distinct physiological patterns is the key to precise diagnosis and targeted care. Understanding the hidden link in chronic musculoskeletal pain is vital for effective treatment.
We now know that 64% of patients with conditions like fibromyalgia or EDS also suffer from dysautonomia. In fact, chronic pain patients are over twice as likely to experience autonomic dysfunction compared to healthy individuals. Since pain actively alters the central autonomic network, screening for dysautonomia is no longer optional. It's the missing piece of the puzzle for long-term patient recovery.
To effectively address autonomic failure, we must trace the wires back to the root cause. Dysfunction is either primary, an intrinsic flaw within the nervous system itself, or secondary, where it's triggered by an underlying systemic issue. Secondary causes are incredibly diverse, spanning autoimmune responses, metabolic conditions like diabetes, and even post-infectious trauma. By distinguishing between an inherent system failure and a secondary reaction to illness, we can move beyond managing symptoms to treating the true source.
To accurately diagnose what's often hidden, we rely on a specialized diagnostic toolkit. The tilt table test and Ewing's battery are essential for mapping autonomic responses like heart rate and blood pressure under stress. For a deeper look at nerve integrity, we utilize QSART to measure sweat reflex and skin biopsies to physically quantify nerve fiber density. Together, these objective assessments bridge the gap between subjective symptoms and definitive clinical proof of underlying dysfunction.
Improving your quality of life isn't about finding a single magic pill. It's about building a stable system from the ground up. We begin with a solid foundation of lifestyle and non-pharmacological habits. Once those are established, we can introduce targeted pharmacological levers for more precise control. Finally, we integrate advanced therapies to optimize results. By layering these interventions thoughtfully, you reclaim your autonomy and create a sustainable path to long-term health.
To truly rewire your daily baseline, we start with 4 fundamental interventions. First, aim for 1 to 2 liters of water daily to expand blood volume. But hydration needs a partner. 4 to 6 grams of sodium ensures that fluid stays in your bloodstream. We then add medical compression to prevent blood pooling in your lower body. Finally, by shifting to small, frequent meals, we prevent blood from being diverted away from circulation during heavy digestion.
To stay ahead of symptoms, we must proactively manage key physiological triggers. Heat exposure causes rapid blood vessel dilation, so prioritize cooling tools to prevent sudden blood pooling. When standing, gravity works against you. Incorporate micro-movements or seating to avoid static pressure. Finally, be mindful of alcohol and simple carbs, which divert critical blood flow to the gut. By anticipating these systemic challenges and adjusting your environment, you can maintain much better stability throughout your day.
Moving to Tier 2, we introduce targeted pharmacological levers to address specific physiological deficits. First, we use volume expanders like fludrocortisone to artificially boost blood volume. Next, vessel constrictors provide the necessary squeeze that the autonomic system is failing to deliver. Finally, rate controllers help manage tachycardia and enhance nerve signaling. Crucially, in neuropathic cases, beta blockers require careful monitoring, as they can inadvertently worsen symptoms if the core issue is actually impaired vasoconstriction.
Think of your patient's autonomic nervous system as a seesaw. In many cases, especially with diabetic neuropathy, we see a profound imbalance. Fight or flight is hyperactive, while the rest and digest system is severely depleted. To restore equilibrium, we use a 2-pronged approach. Targeted supplementation, like magnesium glycinate, calms the central nervous system, while somatic tools, such as vagal nerve activation and deep breathing, manually re-engage the body's natural brake, bringing the system back into harmony.
Moving into Tier 3, we look at advanced therapies for complex cases. For refractory autoimmune dysautonomia, high-dose IVIG has shown an impressive 88% response rate by modulating the immune system's attack on nerve fibers. When malabsorption is an issue, parenteral B12 therapy bypasses the gut to directly repair nerve myelin. Finally, integrative physical medicine, like spinal manipulation and dry needling, targets chronic myofascial pain to effectively reduce sympathetic overdrive. Effective recovery depends on protecting your energy envelope. On good days, you're tempted to push past your limits, but this spike leads to an inevitable biological crash. To break this cycle, you must practice strict pacing. By deliberately resting before your envelope is breached, you stabilize your functional baseline. This strategy rewires your brain to trust a steady state, avoiding the boom and bust cycle and creating a foundation for more sustainable long-term health. Recovery isn't a single event, it's a flywheel that builds momentum. We start by establishing pharmacological and fluid stability to create a safe baseline. This allows for recumbent exercise, which strengthens the muscle pump necessary to compensate for nerve damage. Improved hemodynamics then lead to restorative sleep and reduced pain. Together, these steps enhance nervous system tone and create the physical resilience patients need to reclaim their autonomy and move toward lasting wellness. To engineer your way forward, start with data. Meticulously track your symptoms and triggers to find the specific patterns that govern your health. Next, build a collaborative team of specialists from cardiology to neurology who treat the whole person. Finally, step into the role of project manager. Lead your care with research, advocate for answers, and never settle for a diminished quality of life. Your symptoms are real, the science is clear, and your autonomy is reclaimable. We are facing a growing crisis that remains largely unseen: the invisible epidemics of autonomic dysregulation. When the internal systems that govern our survival fall out of sync, the impact is profound, yet often misunderstood. Beyond the physiological struggle, patients face a secondary battle: institutional stigma. This occurs when our rigid medical and social structures fail to recognize conditions they cannot easily see. Today, we'll explore how to bridge the gap between biological reality and systemic empathy. To understand the autonomic storm, we must look at the microscopic level. Dysautonomia occurs when small, non-sensory nerve fibers are damaged, disrupting the body's essential autopilot. When these delicate fibers become sparse or dysfunctional, they can no longer accurately regulate your cardiovascular, gastrointestinal, or respiratory systems. This breakdown leads to widespread symptoms like tachycardia, gastroparesis, and severe dizziness. Ultimately, what feels like a chaotic series of disconnected issues is actually a fundamental failure of internal regulation. Think about what happens when you stand. Normally, nerves signal your vessels to constrict, pushing blood upward. In neuropathic POTS, those nerves are damaged. Instead of circulating, blood pools in the lower body. To compensate for this sudden drop in return flow, the heart is forced to race aggressively. This failure to constrict is our diagnostic focus, where we see a heart rate spike of 30 beats per minute or more alongside clear evidence of nerve degradation. Identifying the precise autonomic failure mechanism is vital for targeted treatment. For neuropathic POTS, impaired vasoconstriction necessitates alpha-1 agonists. However, beta blockers may actually worsen symptoms. In contrast, hyperadrenergic POTS involves excessive sympathetic drive, where beta blockers are highly effective. Finally, hypovolemic POTS requires aggressive volume expansion through salt and fluid intake. By utilizing diagnostic tests like plasma norepinephrine or skin biopsies, we can move beyond generic management to deliver specialized, truly life-changing care for our patients.
Our bodies process coffee through a surprisingly complex autonomic lens. For non-habitual drinkers, a massive 53% spike in nerve activity triggers a sharp rise in blood pressure. Intriguingly, habitual drinkers experience that same internal autonomic storm, yet their blood pressure remains completely stable. This demonstrates that factors beyond caffeine drive these spikes, and regular exposure fundamentally decouples our internal nervous response from our outward cardiovascular output. It's a powerful example of systemic adaptation at work.
Opioid withdrawal isn't just a series of symptoms. It's a profound dysautonomic event where the body's nervous system loses control. Within 48 hours, simple anxiety escalates into heart rate spikes and panic. Between days 1 and 3, we see the peak crisis, a period of intense physical pain and psychological distress where the risk of relapse is greatest. Understanding this timeline is crucial, as the neurochemical disruption can linger long after the acute symptoms subside.
Opiate withdrawal is a full-scale biological storm, a total collapse of autonomic homeostasis. By using the Cowes scale, we can map how this crisis ripples through the cardiovascular, gastrointestinal, and nervous systems simultaneously. It's far more than physical discomfort. It mirrors the intensity of a severe, debilitating infection. Crucially, a score exceeding 36 indicates severe multi-system withdrawal. At this stage, the body is in profound distress, requiring immediate clinical intervention to stabilize these interconnected systems.
We are witnessing a profound clinical overlap among these invisible epidemics. Conditions like long COVID, fibromyalgia, and chronic fatigue syndrome share striking multi-system effects that often evade standard diagnostics. While long COVID is uniquely characterized by severe cognitive impairment, the debilitating impact of fatigue is nearly identical across all three groups. Ultimately, patients suffering from a combination of these conditions face significantly increased severity, highlighting the urgent need for a more integrated diagnostic approach.
We often overlook a critical driver of chronic musculoskeletal pain, dysautonomia. It fundamentally alters pain modulation, perpetuating the fatigue and dizziness many patients struggle with. Data shows that 64% of chronic pain patients, nearly 2/3, suffer from objective dysautonomia. These individuals are more than twice as likely to exhibit this condition than healthy controls. To provide truly effective, comprehensive care, we must make routine screening for dysautonomia a standard part of our clinical assessment.
Modern medicine excels at visible trauma, but struggles with systemic dysregulation. When patients present with severe symptoms lacking clear biomarkers, they enter a devastating cycle of epistemic injustice. Their physical suffering is often dismissed as psychological, leading to the denial of essential support and disability benefits. This systemic discrediting does more than withhold care. The resulting gaslighting and stress actively worsen the patient's health, trapping them in the profound isolation of a reality that is systematically debated. Historically, patients with chronic illnesses like ME/CFS face decades of isolation and medical dismissal. However, the emergence of long COVID sparked a revolutionary shift. By bypassing traditional gatekeepers, patients use social platforms to crowdsource clinical evidence and build consensus. This move from fragmented clusters to a massive knowledge network fundamentally changed the landscape. By inheriting existing advocacy infrastructure, long COVID gained WHO recognition in mere months, demonstrating the unstoppable power of patient-led expertise.
Marginalized patients, whether battling chronic illness or navigating opioid recovery, face a devastating dual-front crisis. Internally, they endure a physiological storm of massive autonomic dysregulation, invisible pain that defies simple diagnosis. Externally, they encounter a healthcare infrastructure rife with stigma and gaslighting. This is the ultimate parallel, a body failing from within, met by a medical system failing from without. We must address this systemic failure that leaves the most vulnerable trapped between two collapsing worlds.
While medication-assisted treatment is the gold standard for OUD, 80% of those who need it are currently left behind. This gap exists because of institutional friction, a complex wall of barriers blocking access. From systemic deficits like rural provider shortages to logistical failures like transportation and childcare, the path to recovery is often impassable. Ultimately, the most significant hurdles remain social stigma and personal shame, which continue to be the highest-rated barriers to patient engagement.
Sleep is far from passive. It's a sophisticated biological rinse for your brain. This detoxification relies on 3 synchronized systems. Physically, the glymphatic system expands to flush out metabolic waste like amyloid beta.
Electrically, slow-wave oscillations act as a pump, driving fluid through neural tissue. Neurochemically, drops in norepinephrine create the ideal environment for this deep cleanse. Understanding these mechanics reveals why sleep is non-negotiable for cognitive longevity and clearing the daily debris of neural activity.
Sleep isn't passive rest, it's intense biological labor. During wakefulness, your brain focuses on information, but it also accumulates metabolic waste faster than it can be cleared. To address this, consciousness is suspended to allow a sophisticated system to perform critical maintenance. During sleep, your brain actively flushes toxins, prunes synapses, and consolidates memories. It is an essential restorative process that repairs your biological hardware, ensuring you remain cognitively sharp and ready for the challenges of tomorrow. Understanding how our brain restores itself requires looking at the interplay between consciousness and biology. While wakefulness inevitably leads to waste accumulation, deep REM sleep is where the real maintenance happens. During this phase, brain cells contract, allowing cerebrospinal fluid to clear out 60% of metabolic debris. This physical wash is vital for immune repair. Meanwhile, REM sleep shifts the focus towards emotional and memory resets, ensuring our cognitive systems are fully optimized for another day. Think of deep sleep as a vital power wash for your brain. Since the brain lacks a traditional lymphatic system, it relies on the glymphatic wash to remove metabolic waste. During deep sleep, brain cells actually contract, opening up space for cerebrospinal fluid to rush through. This process increases the clearance of neurotoxins, like amyloid beta, by over 60%. This nightly rinse is essential for long-term cognitive health and protection against neurodegenerative diseases. Why is sleep so restorative? It's all about the noradrenaline valve. When we sleep, a drop in noradrenaline acts as a master switch, causing brain cells to physically shrink. This expansion of the interstitial space opens up a literal fluid highway, allowing cerebrospinal fluid to rush through the tissue. This results in a dramatic 60% increase in waste clearance, effectively flushing out metabolic toxins like amyloid beta to keep our brains clean and healthy.
Now, let's examine System 2, the MHB-IPN circuit, which serves as our brain's critical structural repair hub. This is where anesthesia, sedatives, and natural slow-wave sleep converge. By actively suppressing alert wakefulness and REM, this system forces the brain into a profound offline state. This deep unawareness isn't just rest, it's a vital period of uninterrupted physiological repair. It ensures the brain can focus entirely on restoration without the interference of conscious processing. When our brains detect signals of safety and familiarity, a critical transition occurs. This process is mediated by the MHB-IPN hub, which translates environmental security into physiological action. By integrating these safety cues, this circuit induces a state of reduced awareness. This isn't just rest, it's a vital restorative window where the body activates immune defenses and accelerates protein synthesis. Essentially, feeling safe unlocks the brain's internal machinery for cellular regeneration and neural growth. Moving to System 3, we explore the neurochemical topography that governs our rest. Sleep architecture isn't accidental. It's a precisely staged sequence driven by shifting chemical signatures. As we transition from wakefulness through NREM and into REM, our brain relies on the orchestrated rise and fall of dopamine and serotonin. Understanding these fluctuations reveals how neurotransmitter levels create the distinct neurological states required for deep physical restoration and the dreaming mind.
Dopamine is often linked to reward, but it also acts as a critical on switch for REM sleep. Think of it as a delicate seesaw. A precise transient burst of dopamine is required to initiate dreaming. However, if levels spike too high, your sleep architecture fragments, causing insomnia. If dopamine is depleted, you lose the restorative REM phase entirely. Achieving healthy sleep isn't just about closing your eyes. It's about maintaining this exquisite neurochemical balance.
Chronic sleep restriction isn't just fatigue, It's a systematic dismantling of your brain's maintenance architecture. First, we see physical failure as the glymphatic system stops clearing toxic amyloid plaques. Then, cognitive circuits in the prefrontal cortex overload, crippling memory and focus. Finally, your nervous system's chemical balance shifts, making you significantly more sensitive to pain. This cascade proves that sleep isn't a luxury, it is the foundational architect of your biological health. When we deprive ourselves of REM sleep, we're doing more than just feeling tired. We're triggering a damaging chain reaction in the brain. To compensate for disrupted dopamine, the prefrontal cortex overproduces D2 receptors. This overcompensation backfires, physically severing the vital connections to the basolateral amygdala. The result is a profound cognitive cost. The breakdown of these neural pathways directly impairs our spatial memory, making it harder to navigate and process our world.
Have you noticed that physical pain feels more intense after a restless night? This happens because sleep deprivation depletes NADA, a vital endocannabinoid that regulates our pain threshold. Without enough NADA, receptor activity degrades, leaving your nervous system hypersensitive. As sleep loss persists, your sensitivity to pain, or hyperalgesia, spikes significantly. Essentially, your body loses its natural defense against discomfort. Prioritizing sleep isn't just about energy, it's a critical strategy for managing physical pain.
Sleep deprivation triggers a destructive biological cascade where systems don't fail in isolation, they collapse together. It begins with impaired detoxification, allowing toxic waste to accumulate and degrade brain structure. This physical decline drives cognitive impairment and dopamine overload, which in turn spikes our sensitivity to pain and stress. This heightened stress further fragments sleep, locking us into a self-reinforcing loop. Ultimately, a failure in one system rapidly accelerates the total systemic collapse of our physical and mental health.
Many of us believe a single weekend binge can wipe away a week of chronic sleep debt. Unfortunately, it's not that simple. Functional recovery is a precise equation that requires more than just extra time in bed. To truly reset your system, you must maximize both sleep duration and sleep intensity, specifically that deep, slow-wave energy. True restoration only occurs when both factors peak simultaneously. It takes consistent, high-quality rest to truly overcome a significant deficit.
Think of sleep not as a luxury, but as a non-negotiable biological mandate. When we cut corners on rest, we effectively shut down the brain's automated maintenance systems. True optimization only begins when the lights go out. During these hours, your brain initiates a vital nightly cascade of physical cleansing, neural circuit repair, and essential neurochemical recalibration. To prioritize sleep is to ensure your biological hardware is restored, refined, and ready for peak performance the next day. Small fiber neuropathy often feels like an unsolvable puzzle of pain and numbness. But what if we shifted our focus from simply masking symptoms to actively rebuilding the neural architecture? Today, we're exploring the restored circuit, a comprehensive blueprint designed to stimulate nerve regeneration and stabilize the delicate pathways of the peripheral nervous system. By treating these fibers as a repairable circuit, we can move beyond chronic management toward true functional recovery and lasting relief.
Imagine a patient enduring a chronic, invisible fire, severe burning and stinging that never lets up. For many, the diagnostic journey ends in frustration when their EMG and neurological exams return as perfectly normal. This clinical paradox can lead to the false conclusion that nothing is wrong. We must recognize that the pain is entirely real. A normal test result simply means we are measuring the wrong wires, while the true pathology remains hidden.
To understand how our bodies process signals, we must map two distinct systems. Large fibers act as heavy cables, managing motor strength and balance through thick insulation. These are easily measured by routine nerve studies. Conversely, small fibers function as delicate microwiring, governing pain, temperature, and vital autonomic functions. Because these tiny fibers are invisible to standard EMGs, they often represent the missing piece in diagnosing complex neurological symptoms when traditional tests appear normal.
Small fiber neuropathy is often the hidden driver behind complex chronic syndromes. While frequently associated with burning feet, SFN is the objective pathology beneath broader labels. For instance, over 60% of fibromyalgia patients show evidence of small fiber damage. In long COVID and POTS, this same nerve damage disrupts autonomic control and fuels post-exertional malaise. By looking past these syndromic labels to identify SFN, we can finally address the biological root of these debilitating symptoms. To fix the short circuit, we must first identify what's blowing the fuse. In nearly half of unexplained cases, the culprit is actually underlying metabolic issues like prediabetes. But it doesn't stop there. We also see the immune system turn inward or persistent damage following viral infections like long COVID. By screening for these drivers, alongside nutritional deficiencies and toxic exposures, we can finally move from managing symptoms to treating the actual root cause.
To move beyond subjective reporting, we need objective evidence of nerve damage. The gold standard remains the skin punch biopsy, which definitively quantifies nerve fiber density. Beyond biopsy, we use QSART to measure autonomic function via sweat output, providing a clear functional assessment. Finally, corneal confocal microscopy offers a rapid, non-invasive way to visualize nerve loss. Together, these tools bridge the gap between invisible pain and clinical proof, turning patient symptoms into measurable data. Nerve regeneration is possible, but only within a strictly optimized environment. To achieve this, we must address 4 critical pillars simultaneously. We begin by halting active damage and stabilizing hypersensitive neural circuits. Then, we focus on restoring physical flow through targeted rehabilitation while fueling regrowth by optimizing the metabolic microenvironment. This integrated multidisciplinary approach ensures that every systemic condition is perfectly aligned, transforming the body's internal landscape to support genuine, lasting nerve repair.
To rebuild damaged nerves, we must first stop the damage at its source. You simply cannot repair a circuit if the wires are still actively fraying. This is why metabolic reversal is our foundational pillar. Through strict glycemic control and weight reduction, we shift the body from degeneration to regeneration. Intensive lifestyle interventions can successfully reverse early-stage neuropathy, significantly increasing nerve fiber density over 12 months. It's about giving the body the environment it needs to heal.
Moving to our first pillar, immunomodulation through IVIG acts as a vital systemic reset for autoimmune SFN and long COVID. The clinical data is compelling. 80% of patients with neuropathic POTS see major improvements. For those with Plexin D antibodies, we've observed nerve fiber density increase by over 55%. Most impressively, recent Yale studies on long COVID patients showed a 100% success rate in resolving neuropathic symptoms through this targeted therapy.
SFN often damages the autonomic fibers controlling your blood vessels, causing blood to pool in your lower extremities upon standing. To counteract this, our protocol focuses on 3 key areas. We use mechanical compensation, like compression garments and recumbent exercise, to physically move blood. We also maximize venous return through high sodium and fluid intake. Finally, pharmacological support can help constrict vessels and improve nerve transmission, ensuring your circulatory system responds effectively to gravity. Next, we focus on mechanical restoration, which aims to physically free the nervous system. Nerve flossing is a vital tool here. By alternating tension through rhythmic movement, we mobilize nerves and prevent painful adhesions from forming. Complementing this is dry needling. When chronic neuropathy causes muscles to clamp down on nerve roots, targeting specific trigger points releases that grip. Together, these techniques restore mobility and alleviate the structural pressure causing your persistent pain.